No, it looks great.
Okay, all right. Hopefully this works.
So I think we can advance the slide. I think this is self-explanatory.
Okay. Let's see.
Thanks everyone for bearing with us in terms of the technical difficulties. And then I have nothing to disclose. Next, please.
Okay,
And
ready?
the learning objectives today will be to learn about the history of the prevailing public narrative surrounding drug use and addiction, learn about the implications of stigma for public health policy and federal drug policy, and learn about barriers to access for addiction care, um, you know, which often includes stigma. Next, please. So I thought we'd start with a case. Obviously, this is not the gentleman's actual name, so it's de-identified, but it is a patient that I saw at the adult substance abuse program here at UNM. And so we'll say Carlos is a 20-year-old gentleman with a history of opioid use disorder, major depression, unspecified anxiety, history of syncope and sedative hypnotic use disorder, PTSD, insomnia. A lot of those diagnoses may fall just under a PTSD diagnosis, but he also had a history of hypertension, and he presented to ASAP for intake and had a history of a suicide attempt a couple years earlier. He had a recent inpatient admission in August of 2019 for seizure activity secondary to benzodiazepine withdrawal after being prescribed a pretty hefty dose of alprazolam by a prescribing psychologist who was actually pretty predatory and ultimately had his DA removed and was his license removed in the state of New Mexico. And he was ultimately taking advantage of people and getting them addicted to alprazolam while they were on methadone, etc. Upon the patient's discharge from UNM, they were able to taper his benzodiazepines and switch them over to a safer long-acting formulation, and also keep him on his methadone simultaneously. And he mentioned that things had been quite difficult for him recently, but he was care at ACE. Next slide, please. So just continuing the case. So he ultimately made, significant progress with respect to his benzodiazepine taper here, inpatient, and then also at ASAP. And we felt comfortable holding him at his current dose of diazepam, and continued his other discharge medications. We got him a psychiatric evaluation, but he continued to struggle with PTSD symptoms, and we felt that trauma-focused therapy and psychosocial support would be critical for him. Next slide, please. But ultimately, when we discuss patients like this, a lot of some of the social factors and underlying context is lost. Like many people that we see at ASAP and other addiction, clinics, or even primary care clinics where you're handling folks with substance use disorders, they're often self-medicating trauma or other concurrent mental health disorders, which need to be treated, simultaneously and in parallel. This gentleman also suffered from a significant lack of access to care, which made him predisposed to predatory prescribers like that Rick Wilson person. And, he was very vulnerable. And as kind of like an intro to the main focus of this talk, I think it's important to emphasize that people with addictions face significant stigma in society. And this is due to a public narrative which involves systemic racism and is also involves an illegitimate moral condemnation and criminalization of drug use. Next slide, please. So I wanted to start with a little bit of a history lesson because, when you think about it, tobacco and alcohol kill probably easily 500,000 people a year. But those drugs are legal. And why are those drugs legal and other drugs are not legal? And my argument really is that the reason tobacco and alcohol are legal is because they're the drugs that are enjoyed by old, powerful white men. And other drugs are illegal for reasons that we'll discuss right now. So this is a quote from John D. Ehrlichman. He's a former high-level Nixon aide. And this was an interview that he gave after leaving the administration, after Watergate and all that stuff. I'm just going to read it. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So, as I'll get to in the next slide, please, and this is a little more history, but the point is that a lot of the attitudes around drugs today, specifically the moralization about people who use drugs, was highly manufactured for political and racist reasons. And it's important to understand where our implicit bias may come from when we're interacting with people with substance use disorders and addictions. This is another kind of just historical note, just to kind of, add to the some of these origins of our perceptions of people who use drugs. But, the American policy criminalizing drug use can be traced even further back to racist and xenophobic sentiment in the early 20th century, where, a major motivation for regulating and criminalizing marijuana had to do with racist attitudes towards Hispanics and African Americans. This classic trope that they would assault upper class white women and that kind of thing, which is shameful and egregious in my opinion. Next slide, please. And then finally, even going back to 1911, in California, they believed that marijuana was being brought in by immigrants, and these people were undesirable and they were corrupting white folks, and so this tradition of ostracizing and persecuting targeted minority populations goes very far back in American history, and it started shaping social structures to fit within the establishment power hierarchy and conservative ideology of the upper class white establishment. Next slide, please. Thank you. And so all of these sort of policies and intentional formulations of a public narrative around drug use and addiction contributed to something which exists today in a very harmful way. And health-associated stigma, as many of you who work with people with addictions, is a tremendous barrier for people to access appropriate treatment because they're shamed, they're often discriminated against, and they're distrustful of the medical establishment. But just to really drill down particularly on health-associated stigma, it involves a socio-cultural process in which social groups are devalued, rejected, and excluded on the basis of a socially discredited health condition. And that results in social subordination and the compromise of self-determination. Next slide, please.
Webinar. You good? I guess.
And then there's also social and structural stigma on a higher level, the phenomenon of large social groups endorsing stereotypes about and acting against a stigmatized group. And this results in rules, policies, and procedures of institutions which limit the rights and opportunities of stigmatized populations. I would offer as an example, the fact that methadone is highly, highly regulated on a federal level, which reduces access and flexibility and our ability to appropriately distribute that life-saving medicine. Methadone clinics are often also located in industrial parts of town, because there's a not in my backyard attitude by the public about where they're located. So those are just a couple of examples. And then, so today's narrative has really, in the popular media and in the popular consciousness, often considers people who use drugs to be a moral failure, and that the suffering that they experience is brought upon themselves and they've made that choice themselves, and that they do not deserve help, and that substance use disorders are not a disease. And this is all very counterproductive, in my opinion, from a public health perspective. Next slide, please. So this is just a really, concise quote, and I'm not trying to do death by PowerPoint with heavy text slides, but I sometimes I find it maybe not necessary to paraphrase something that's said very eloquently. So this is from Michelle Williams, the dean of the public health school at Harvard, and she says that stigma is a formidable barrier. Our country has ostracized, punished, and in some cases even criminalized addiction, and that has led people who know that they need help to avoid asking for that help. Even when they do work up the courage to go in and seek that medical care, there's no guarantee that that courage will be met with the appropriate response. Next slide, please. And one more quick quote from a gentleman at the Kennedy School. Stigma and discrimination around opioids is tied to America's tortured history of race relations. Their association with poverty and minority communities prompted a response focused on criminalization rather than public health. Next slide, please. And finally, German Lopez. I encourage you to check out their writing if you have a chance, but they've written extensively on the opioid epidemic, et cetera. And their quote is, "Addiction has notoriously been characterized as a moral failure. The most common response I get to any addiction story argues that overdoses are just Darwin's theory in action." Next slide, please. And so just circling back to that quote from the Nixon aide, that attitude and the goals that they laid out in that quote resulted in the Controlled Substances Act of 1970. And, we're all familiar with the term controlled substances, and this is where that came from. So they criminalized certain drugs and substances, essentially for politically and racist reasons, so that they could persecute certain populations that they considered to be political threats. And it also established the DEA, and it basically launched the war on drugs, which the focus was criminalizing drug use, and has been largely a failure. It's become a war on people who are suffering from a disease, and has resulted in 4 decades, if not more, of rising drug overdose deaths. There were, close to 110 or 120,000 drug overdose deaths in this country in the year 2022, I think, which is the most recent data, which is appalling. And, so what we're doing is not working, and the status quo is unacceptable, in my opinion. Next slide, please. So I talked about this a little bit, but what has happened in the 50 years since the Controlled Substance Act? Drug offenses are the leading cause of arrest in the US. Dramatically exacerbating mass incarceration. Many people who are incarcerated are disproportionately people of color, and they have been incarcerated for nonviolent drug offenses. And as we know, being any contact with the criminal justice system, let alone long-term incarceration, only serves to exacerbate mental health issues and jeopardizes people's prognosis in terms of their mental health and recovery. It has not reduced drug overdoses and has come at a tremendous cost to taxpayers and to our society. Next slide, please. So, there are other countries who have done things differently than the United States. One example was in Portugal, and they suffered from a devastating opioid epidemic in the 80s, not unlike ours currently, with high rates of overdose and disease transmission, such as hepatitis C and HIV. I was fortunate enough a couple of years ago to attend the harm reduction conference in Porto, Portugal, where I got to kind of see their system in action, which was pretty cool. And, one of the things that they did in the 80s was to decriminalize the individual possession of small amounts of all drugs. So they didn't legalize, drug trafficking or drug distribution, but they made it so that the people who were just, using drugs for personal reasons, that they decriminalized like 2 grams of heroin or less, or maybe 1 gram or less, or 1 gram of cocaine or less. And it wasn't that people just got off scot-free, but if they're found to possess these substances in small amounts, for example, by a police officer, instead of going straight to jail, they would be mandated to meet with a social worker who would discuss, with them in a holistic and, non-judgmental way, their drug use and decide whether they had a substance use disorder in the first place. And if they did, they would be, encouraged to go into treatment rather than just being incarcerated. And, so I feel like this is a much more humane, evidence-based method of treating addiction rather than simply incarcerating people who are suffering from a disease. The other thing they did was made methadone and other treatments widely available. They had mobile methadone vans where they would go and distribute methadone very liberally. Whereas in the United States, methadone and to a lesser extent Suboxone, i.e. buprenorphine, remain restricted by cumbersome federal regulations which reduce access to this life-saving evidence-based treatment. And there is, to a large extent, the drug epidemic in Portugal has been eradicated and has been celebrated as a model internationally. Next slide, please. Other steps that we can take to help ameliorate some of the issues we're discussing here is redirecting resources to fund research and health services like evidence-based treatment, harm reduction, and housing first policies. Removing outdated and harmful restrictions on methadone and buprenorphine, which decrease access to care, and repealing laws that restrict employment and educational opportunities, denying access to housing, voting rights, and governmental nutrition assistance programs, and cost people their children or immigration status based on a drug arrest or conviction. And, quite frankly, people don't need to be drug-free to deserve basic human rights, access to housing, decent health care, etc. Next slide. So this is a busy slide, but basically Oregon tried and has implemented a similar thing to what I described going on in Portugal. There's been a lot of headlines recently about how it's not going well, etc. But I think that stems a lot from difficulty with funding and difficulty with distributing those funds effectively so that the model can function optimally. And, a lot of time with big grants or large amounts of money in the hands of bureaucratic public health institutions or governments, getting the money out the door effectively and implemented effectively is a major barrier. And I think we're seeing that in Oregon. And, I do hope that, they get the support they need and are able to implement the project successfully, because it's getting kind of spun in the media in a way that that conflates homelessness and public disorderly conduct and crime with substance use disorders and addictions, which have very different ideologies potentially and different solutions. So I just wanted to mention that briefly. Next slide, please. So just to summarize a little bit about what we've talked about, it will be very difficult to adequately respond to the pressing national crisis of overdose and substance use disorders as long as they are conflated with moral and criminal issues. People with opioid use disorder, as a result, are not able to get the care that they need and deserve. Therefore, the social stigmatization of drug use has created a systematic disparity in health outcomes for those with addiction, namely fatal overdose deaths. And, people who are addicted to tobacco or alcohol predominantly are dying a little bit older, whereas folks with opioid use disorder are often overdosing fatally in their 20s, 30s, 40s, resulting in tremendous amount of years of potential life lost, which is challenging from a public health perspective and a moral perspective. I'm just checking my time here. All right, so I'm gonna wrap up pretty soon here. Next slide. Let's skip this slide. And we can skip this one too. I think these will be made available. Let's just do a conclusion here. We all must work hard to combat stigma and be aware of our own implicit bias when working with the substance use disorder population. The public health approach, centered on human evidence-based services for people who are suffering from SUDs, must be emphasized over criminalization, persecution, and moralization. Structural factors which contribute to addiction, such as poverty, housing affordability, systemic racism, etc., should be recognized and addressed. The status quo is unacceptable, and the war on drugs has been a failure, resulting in 4 decades of rising drug overdose deaths. And I think that's all I have to say for today. And I don't know if there's time for questions, but thank you very much for listening, and I enjoyed chatting with you.